Добрый день.
Good day, dear friends, dear Alexei, Tatiana, dear colleagues. So the topic of our meeting today, can you hear me? So the topic we're discussing today is became really the top priority of the healthcare. So primary medical help is very important. And I remember different stages, and during 20 years that I've been preparing physicians, there'll be different stages. And as Mr. Sobyanin said, the primary healthcare is like this foster child of the whole healthcare system. And it was very unfair, and it's very nice that now the situation has changed. And at the top political level we can hear that the primary medical help is very important, and it is really important because nothing can replace the early diagnosis or change the replace prevention. Nothing can really create such an economic impact as a very well organized primary health help. And it's great that the city of Moscow, which is usually the leader, the driver of other cities, Moscow has done a lot already and organized such an exhibition where we can see all these achievements. So it gives me a great pleasure to give the floor to the Ministry of Healthcare of Moscow and the head of the Department of Healthcare of Moscow, Professor and MD Alexei Khrypun. Thank you, Georgy. Good day, dear colleagues. We just were at the plenary session, and for many times we heard the question from the host and from speakers: what's more important, inpatient or outpatient health care? And we heard the answer that both are important, and we have to develop them at the same time, these both areas. And this discussion started at 8 o'clock here, when with many speakers we discussed the same topic. And overall, it feels like the global trend is, of course, the development of both areas, but with the switching of focus to inpatient clinics. So in Moscow, every year around 2 million people are hospitalized, and 100 million during the last 3 years. Its figure is quite stable. That's the amount of people who come to outpatient facilities. So at the same time, in 2019 we paid a lot of attention what were the reasons, at what time, and with what results patients as our outpatient facilities were, and we noted, though we expected such a result, that amount 20–30% of patients who received this outpatient medical help, who received inpatient help, they could have been treated in outpatient facilities. And that's a very serious conclusion. So are we ready today for this? Almost ready. When we create special conditions, we can do that. And the conditions are to reallocate our resources to outpatient facilities. Now about 60% of funding is for inpatient facilities and 40% for outpatient. So today, resources as for staff and for material resources, they are mostly in inpatient facilities than in outpatient facilities. So how can we reach the balance and reallocate the highlights? So today in the morning and during the plenary session, for many times we heard recipes how we can achieve that. For instance, to achieve the full integration, we should start with accumulating data. We need the common goal. That's how the plenary session was finished, almost by the same words. We should work as a team, and many other things. So we're following the same way. But our priority now is to standardize of outpatient help in Moscow, which means four main components. First, it's staff provision. So you most know this Moscow outpatient facility plus standard. So at the first level we have at least 8 the most in-demand doctors. Our outpatient facilities that work on the second, more professional level, they should have 5 more specialists. That's the minimum that we would like to achieve. We noticed that in some polyclinics and some outpatient buildings, which are 440 outpatient facilities, and about half of them are for adults. And in 2019, there was a shortage of 500 doctors, according to this standard. Now we almost covered this shortage. We hired about 300 doctors of different specialties, and I'll talk about that later. Affordable diagnosis. We know that our clinics are not equipped very well. And we know that in some polyclinics, in some outpatient facilities, there may be equipment which is already outdated, or there is shortage of some standard equipment that should any outpatient facility has. And so now we'd like to create the standards what kind of equipment and what numbers each outpatient facility should have. So they should have mammograph, ultrasound, some lab equipment, and some diagnostic tools. So the second tier outpatient facilities should have CT, MRI, treadmill, and what's most important, both at all this level equipment should be digital, because accumulation of data is a key tool to achieve integration of the whole system of healthcare in the city. The new rules of zoning in our clinics, how patient goes from the entrance till the reception of medical help, may be very different and quite often subpar. So this year we're starting to standardize all Moscow outpatient clinics, their resources, and we're starting doing that, thinking about what departments patients visit, so how to organize pathways within the building to make their trips shorter. Now we understand that our clinics need more open spaces, clear navigation. So all these standards are developed now. And at this exhibition, if you pass the area where there are models of our sites, of the new capital repairs and construction, you could have seen that. And comfortable conditions both for personnel and for our patients. So the most important, that everything that I mentioned, that every Muscovite, every citizen can have the same equal accessibility. So from the point of view of accessibility and affordability of the medical help and its the amount of its resources. 135 buildings will be repaired next 3 years. 50 of them will start to repair and equip already this year. Now we're almost done with project part, with the designing, and in the future we'll have a complicated task to free these buildings and then to provide Muscovites with such medical help that this stressful situation would not be so painful for them. So all these standards that I mentioned earlier, so they're all done within this capital repairs of Moscow outpatient clinics. So patient 2.0, how does it start? That we discussed a little bit at the plenary session. How can we help? How can we inspire a patient to cooperate and to actively participate in their own health? That's a question that many of us are worried about, and the way is through our preventive work and regular exams. So Moscow National Community knows very well the name of Semashko, and many of us are being taught that it's much easier to prevent an illness than to treat it. But the structure and the service and the principles and technologies of these regular exams and checkups that we have right now, and the work that we do is for prevention, they can't and they don't really attract Moscovites for this, to this important testing in their lives. So what are we doing and what are we about to do? So regular checkups in Moscow will be smart and convenient. It will have the possibility of different communications through text messages, push notifications, emails. It's supposed, and our partners from the IT department are wrapping up their work. It should have the possibility of remote appointment. It already has, and in summer we saw it in our pavilions, of the possibility of surveying with automatic treatment, processing of these surveys, and automatic navigation, and the possibility of green corridor to go to the specific tests that were defined at the survey level. And finally, these digital medical documents and these regular checkups, they allow us to accumulate all kinds of data. For instance, 2 million Muscovites are regular in hospitals, so the data of their medical history in the hospitals should also be available to this sort of passport, this ID of a person, health passport. So, until we have this integrated, unified system, where we'll have not only outpatient facilities but also inpatient facilities, you understand that we're working on it within already 1 year, and within 1 year and a half, 2 years, we'll have this unified system. Is it all possible? Yes, it is. And most of people here participated in the in this work to organize these pavilions, Health in Moscow. They were in 46 Moscow parks, and over 430,000 people visited it during 3 months. So it's 124 days. And you can see here the slide. So it allowed us to achieve very good results for analysis and further work with these patients. So what have we done? What did we do with Summer Pavilion? First of all, it's all this common tests for regular checkups. You can make an appointment online. So to their local outpatient facility for other tests, it was also possible. We haven't only achieved a lot of this mass participation of Muscovites in this event. It really allowed us to attract, which is very important, active people in Moscow. Because usually 2/3 of such people can't find time for that. And we really saw it practice our technologies, some new technologies. So this multi-channel notification system that you can pass this checkup. This principle of one window, when a patient comes to a facility, or to this pavilion, and receives this service without leaving the building. consideration of the electronic data in this patient electronic medical card. And so now people who live in Moscow have access to their all medical documents now through some multifunctional centers. So it allows to make our patients the participants for our work. On the other hand, it motivates and make our community more organized. A lab service, a pilot one, and now it's been implemented and distributed in different outpatient facilities, all kind of communications between different buildings and departments when we talk about inpatient facilities. So another type of outpatients, so we have these active patients, and the opposite end of the spectrum is senior people who have all kind of comorbidities and low mobile patients. And so this is very important to how to organize help in Moscow. Here we're also doing a lot. So it's a project how to treat chronic patients. Here we have about 400 doctors and 400 nurses in Moscow clinics. So in the register of this project we have about 200,000 senior patients with chronic diseases. Our specialists who work with them have specific financial incentives, and we select the most professional people for this. So the nursing system, so the social service, who comes to the patient who can't come to the outpatient facility for this or that service, and organize this service at home.
So how can we integrate all these things? And now I would like to get back to the start, to what I started with. So how can we integrate inpatient and outpatient facilities in one single network? We have to create a single information space. Otherwise, it would be extremely difficult to do this. And we are now trying to roll out this work. Hopefully we will complete it within 1.5 or 2 years. You know probably about town of Zelenograd, and last year they decided to set up a single legal person represented by outpatient and inpatient facilities, which will become a pilot platform for us. We are going to test different technologies so that we could identify the continuity between different clinics and medical centers. The key issue to strengthen and consolidate our inpatient facilities and outpatient facilities is staff. And we set up a Moscow HR center, and it's now working. It has already worked with 200 candidates, so they have all taken exams and got the recommendations for work. We are also working with universities, so we're trying to look for the best students, and we're having a joint program for the students. And we can actually provide learning and training on at their workplace, so it's an on-hand training. We started using a new approach to specialist certification, which is quite stringent, and it's going to be quite tough to get through this evaluation, but it gives a chance to prepare for this exam through our professional qualification development programs. To sum it up, the key element of this work is about introduction of new digital systems and new digital technologies. You can see all of them on this slide. So take a closer look. And I guess we will discuss them later on, and it's not the only session that we have touched upon these things. Thank you very much. I would like to ask all the speakers to stick to their timeline. Of course, I can't interrupt the minister because I will have to keep my post and keep working here. But thank you for your address. So I would like to ask you one question. Is there a certain roadmap that can enable us to see what's happening? Of course, you can't do it overnight, but anyway, it would be good to see that, for example, by this time, 75% of services will be delivered in this facility. Do you have such schedule or roadmap? Well, basically, what I have described is the basis for our modernization program of primary healthcare sector. And there are deadlines that have been established. There are some indicators that we have to achieve, different targets that we have set up. Well, I can't tell you that 80% of medical services will be provided at outpatient services, but anyway, it will be much more balanced. And it means that this information is there, is available, and you have a roadmap like this. Yes, thank you. So our next topic is going to be very interesting as well, and it's about a general, universal trend in the world. We already said that this primary care should be more productive and include most of aspects of healthcare. And it would be interesting to listen to our other speakers. Ekaterina Shapochka, actually it's her area of professional interest, and I would like to ask her to share her report with us. Thank you. Thank you, Grigory. Hello. Good afternoon. Today, the plenary session, we have already discussed the different trends that have an impact on healthcare. And of course, primary healthcare cannot be isolated from this. I would like to remind you of certain trends and maybe add to something that has been said already in the plenary session. So what do we see is that healthcare becomes more complex, more complicated, so rehabilitation and basic services move to different formats, new technologies and digitalization is moving forward, so we're trying to find precise medical services. Now healthcare is focused more on preventive medicine, and urban environment has already been mentioned by the mayor of Moscow. The urban environment has become more healthy, and so that's why we can see that a new healthy way of life is being shaped. Now the patient becomes the subject of healthcare, so it drives doctors' competences, and the role of primary healthcare is expanding, so it becomes the connecting link between different formats that have already said. And we can observe two major trends if we speak about transformations. First thing is stepping away from outpatient facilities. So we have already seen that minimal invasive surgeries, rehabilitation is moving along the strand. Now the transformation of primary sector overall. Now all citizens can get their services not just at clinics but also at work and in the parks. Telemedicine allows you to do many things and some minor procedures can be conducted by patients themselves. So home-based standard is one of the key trends, and local medical aid is one of the elements. So community care is a combination between medical and social help. So here you can see the description of its major elements, and on my next slide I wanted to share some of the examples. So if we move from left to right, you will see how important the role of medical help becomes. For example, in Australia we can see only rehabilitation as medical help, whereas social system, including volunteers that work with the patients with dementia and other mental diseases, become more and more important and essential. Now in the Netherlands, people work a lot with disabled people and elderly people, so mid-range medical personnel play a very important role here. And if we take a look at the US, we can see the city block, a full-scale medical help where the general physician is responsible for a certain area and a certain number of patients. So he becomes a coordinator between social services, insurance companies, diagnostics, and developing the pathways for different patients if they have some chronic diseases. So I have mentioned different formats that you can see, but how can we coordinate this? Alexey Ivanovich mentioned this before. We can see different ways of coordination, and in particular it's very interesting to see whether there is a formal position of coordinator. So basically we call this person an account manager who is responsible for coordination and pathways that the patients take in line with the recommendations. This is a very expensive system, and especially people with comorbidities, with some complications, with some difficulties and chronic diseases, and elderly people belong to this category of patients. And of course the integration of information systems and databases is a key to success. We are moving from very simple basic forms from electronic records where the patients can enter their data towards the integrated system, integrated databases that can be shared by private clinics. So the patient can decide who he wants to access his data. So you can enter any data there, and then we can see how effective the treatment was. Another thing that affects the primary health care is preventive care. I have 2 more minutes, but I'm coming to an end. So this diagram shows you how it moves from mass-scale prevention towards individualized cases and groups of risk. So there are also predictive analytics that you can see on the right, which can help us to predict the development of disease. So there's been a lot said about city environment, and it's not just the street, it's not just the sidewalk. We're trying to make our city environment as friendly as possible. So it's a great example that you can see here, health tents. and it's been very, very effective to involve the patients that can help them to control and to manage their health. And finally, let's talk about patients. Patients are changing. Each patient wants to check some information on the internet before going to the doctor. They can see what kind of prescriptions they can get. The patients want to get involved in it. They want to see what kind of prescriptions they get. And of course, there might be some problems related to communication. It might need some extra time of the doctor, some additional communication skills that the doctors might obtain as part of lifelong learning. And this learning and education has to be continuous. So this is what I wanted to tell you. Thank you very much.
Опять же, есть так как один вопрос. Скажите, пожалуйста, вот есть какая-то роль телемедицины вот в этом взаимодействии?
So, what kind of role telemedicine play here? Is it emphasized, or it's just part of it and it just fits in smoothly? Well, whatever we can move from primary healthcare home, and it's about monitoring in the first place, because it's been described in legislation, so it's allowed to do in many countries with regard to certain diseases, and there could be different doctors' council meetings, and it's part of information support. Thank you very much. I would like now to give the floor to Chris Borg, and when Mr. Borg is going to speak, I wanted you to focus on the fact that the UK spends on healthcare twice as little as the US. But despite this fact, they have very good indicators, much better than American indicators. And that's why I'm sure that this experience is very effective and deserves our attention. The floor is yours.
Thank you very much. And thank you, and apologies that I cannot speak in Russian today, so I'll try and speak reasonably slowly. Thank you very much indeed for letting me take part in this wonderful Healthy Moscow Assembly. It's very impressive. Well, I wanted to talk a bit about prevention in primary care. And of course, prevention and indeed care and treatment in primary care only works if people use it. And I know this is a challenge in many countries, but in the UK, 90% of healthcare by volume is undertaken in primary care. So most people, they're all registered with a GP, and most people use primary care. And that's very important. That's why do people do that? It's because something we talked about in the plenary, it's maybe about trust, that we have doctors and professional teams working alongside family doctors, GPs, who are well trained, well remunerated, and therefore people trust them to do a good job. Closer to the mic. Okay, thank you. So that's the first thing. If you want to have prevention and treatment in primary care, people have to use it. Some things we are doing sometimes, we take primary care to the hospital. So for people who go on to a hospital for an emergency, we also sometimes put GPs in the front door to help support people who do not really need to come to the hospital, either for outpatient or inpatient treatment. And that is one possibility, is you take primary care to the hospital. So what do we actually do in the way of prevention in primary care? I think we've talked about a lot of these themes already. One of them, of course, is immunization and vaccination. That is one of the best interventions you can make to improve health of a population. And we're aiming for 95% of all children to have the immunizations that they should have. And we're quite close to that, and there are some challenges that we talked about in the plenary about trust again in vaccination, but we have a good record there, and people do use the GP for immunization. As well as face-to-face consultations, we have a 24-hour telephone system, the NHS 111 system, which people do use to get initial help and then to be referred on if needed. and similarly a website, 111.nhs.uk, where people can get a lot of health information, which they again can trust because it's been accredited by the National Health Service. And then if you're already ill and wanting to prevent yourself having a relapse or having further problems, GPs, we incentivize GPs, we give GPs extra money for keeping registers of people with particular illnesses. There are 19 different conditions that GPs are incentivized to keep a register, and not just a register, to actually be active in reviewing those cases and risk managing them, in deciding what treatment they need, but also giving them preventive interventions such as prescribing statins or referring people to smoking services and so on. So that's important with people who are already ill. There are also now, we have developed quite a few specialist services within primary care, so you don't have to go to a hospital setting for example, psychological therapies. So now everywhere in the UK you can get psychological therapy. That was seen as a lack in our system. You could get psychiatric care, but psychological therapy was not sufficient, and now that's available everywhere. And that's been a really important primary care-based service. Together with some other more specialized services, for example, for drug misuse, for homelessness, etc. And then we've talked a lot, I think, about digital systems, not just telemedicine, but digital systems as a whole. And I think particularly for tech-savvy people, and it's not only young people, but maybe mainly younger people, then having access to behavioral apps that can help you stay healthy, screening apps that help you decide if you've got a problem, GP consultations through an app, as well as a range of other consultations. Also case management to help clinicians and patients work together on managing their long-term condition, as well as having remotely guided treatment and online rehabilitation and self-management. And then finally, I think it's important to have a series of services within primary care that the GP can refer to. So if you do smoke and you want help to stop smoking, and we know that you've had a dramatic decrease in smoking in Russia, and I think we've seen that as well in the UK. And one of the ways we do that is by having a stop smoking service in primary care that we've found that you're much more likely to stay off the cigarettes if you have that additional help. And there's also one of the biggest prevention programs in the world, which is our diabetes prevention program, helping people who are at risk of developing diabetes stay healthy. And there's increasingly weight management services available, etc. So that's been really important. But I think the Minister and Ekaterina have talked about the importance of coordination. And I think for us, the GP is the main coordinator. So he or she cannot do all the work herself, but they can coordinate the team and coordinate the treatment across these various services and also back into the hospital. And having good digital links with the hospital is really crucial to this. I think the other thing we've done organizationally is put GPs in the driving seat. So we've asked clinical doctors, GPs, to take responsibility for their population. We've given them a lot of the money that the government gives for healthcare and asked them to work together to decide how that money should be spent on healthcare. So GPs are driving the development of healthcare across the whole system, including hospitals, through something we call clinical commissioning groups. And we've also started putting together lots of groups of practices working with community-based services into what we call primary care networks. And these develop a whole range of preventive and treatment services by integrating the services in a particular population of around 30 to 50,000 people. Of course, in all this, the patient's voice is critical, so having patient participation groups, having surveys, etc., has been critical in developing those services, as we've also heard you're doing in Moscow. So does it work? And you would ask me the question about the cost effectiveness of the British system. And it is, I think, we are significantly cheaper per head of population than probably all our other developed country, Western country, anyway, comparators, and certainly significantly less than the US. And it's because I think we have a single public system that provides access to healthcare made pretty easy because of the range of services I've talked about, including the GP, but also all the other ones. And that means that everyone is managed as an individual patient throughout their life and through all their pathways with a consistent sharing of knowledge and information and data. And I think that has enabled us to not overuse hospital, not overuse interventions. If you look at, for example, cesarean rates, we're much lower because there's no incentive to do more cesareans unless it's really needed. So we could talk a lot about that. But it does seem to work, and primary care we know is associated with lower mortality, better clinical outcomes, as well as cost effectiveness. So developing the primary care service is the right direction. So it's the basis for prevention, it's the basis for care and treatment. I think the challenge we have, we talked about value-based, this is my last point, we talked about value-based healthcare, which is very important, but actually developing remuneration systems, payment systems, linked to outcomes, I think is still really difficult. We're still struggling with that. How do you really measure the impact of all your interventions? Some we can see in specific detail, like stop smoking services, but I think in terms of paying people according to the overall outcome is going to be difficult. What I do think is right is moving towards, as we talked about in the plenary, more of a cluster approach that you pay people for the total treatment of an individual patient rather than the specific interventions. But again, I'm very happy to discuss that. Thank you very much for your attention. Thank you.
Thank you very much, Mr. Bourne. I think it's a wonderful experience that of course we will exchange our experiences, and then Mr. Martin Gilbert, and the topic is a shift of medical services through the development of integrative models. Please, Mr. Gilbert, the floor is yours.
Thank you very much, and my apology also for my inability to speak in Russian or even understand much of Russian, but I hope to learn someday. What I'd like to speak about, and a little follow-on from my discussion at the plenary, is what I'm going to call primary care 2.0, which is sort of primary care in an integrated care setting. And it's, you know, it's very much of the roots at Kaiser Permanente. And for those that don't understand that organization, what Kaiser is, it is a not-for-profit private healthcare insurer and delivery group. But it gets one amount of money for each individual each year, either from individuals or more often from employers to do the care. So it is what we call a capitated model. But once that capitation comes in, it's up to Kaiser to figure out how to best use that money to deliver the best care to patients. And Kaiser does, I mean, US is not the best example of economics, and there are many factors leading to that, but Kaiser tends to do it 15 to 20% cheaper than our competitors in the United States, for a US example. But part of that is because we actually have learned long ago that prevention pays, and also managing the patient as a whole pays. And when we look at this sort of primary care 2.0, another name commonly used in the United States is medical home model. But primary care isn't just a doctor. It is actually a doctor who is supported by a team. That team will always have nurses. It'll even have a receptionist who can communicate with patients, but also as a social worker who can, you know, help assess mental health needs as well as help coordinate social activities. And that nurse can also help coordinate activities, you know, in chronic disease management, as well as coordinating care when patients do need to go to hospital or getting home health services. We look at this primary care 2.0 hub as every patient in Kaiser Permanente is associated with a primary care doctor. I have one, so does every Kaiser member. And that is sort of, as I said, your hub. That's where your center comes from. And that hub in Model 2.0 is a very digitally enabled hub. That doctor doesn't have to fish through records to understand the issues of his or her patients. There's data analytics and whatever that support who are your highest risk patients, what patients haven't come in that should, what patients aren't taking their medications, what diabetics are in poor control, what people in your practice are at risk to have eventual kidney disease. From information that patients fill out either digitally when they arrive or at home, there are analytics that help that primary care team understand who's at risk for depression or who is at depressed. And I think if you look, and I haven't had the opportunity to visit a polyclinic here in Moscow, but my guess and my assumption is that those primary care doctors are seeing patients one by one by one. If you go to sort of the Kaiser 2.0 model, the primary care physician is maybe only spending 35 to 40% of his day or her day in one-to-one face-to-face visits. Part of the model, as that trust and that health information stays with that doctor, allows for half of the actual visits become virtual, either via video or via phone, and that occurs during the day in between those face-to-face visits. But also the doctors spend about 20% of their time with their staff looking at which patients are at risk, which patients perhaps are lost to follow-up, who hasn't been in, who could be in, who hasn't refilled their medication. Even myself, I'm genetically at risk with hyperlipidemia, so I'm on a medication to lower my lipids. Oh my God, if I don't refill my medication every 90 days, someone calls me, you mustn't be taking it every day. So little things like that, but 20% of the primary care physician and their team spends actually looking at the data and looking at how their patients are performing. And part of that also means that they're actually looking at probably about 2 hours every week. The nurse and doctor sit down and say, well, look who's on the schedule for coming in next week. Are they up to date on things? Shall I ask them to get an X-ray or a blood test before they come in to make that visit much more powerful? So I hope what I'm trying to illustrate to you is how digital and data, and you have a great start here in collecting it, but how actually in primary care that can be used to help you manage your patients and the population remotely from afar, and also take care of as many issues as possible once they do come in, and be able to support them. The other piece in that, as I said, the doctors have significant time not doing face-to-face visits, is many times a patient's care requires consultation with a specialist. But not every time does that patient have to go to the specialist. So primary care doctors at Kaiser Permanente are very well connected with specialists, and specialists are available either via secure messaging or via telephone real time to actually do consultations doctor to doctor. So for many conditions that classically primary care doctors have sent their patients to the specialist, this time the doctor takes the patient's data. Sometimes we'll have a photograph of something or another, a radiograph, etc. Can actually do that consultation remotely and then get back with the patient. Also adding to that trust and that long-term relationship with primary care. So hopefully what I've been able to describe briefly here is sort of taking a lot of the groundwork and so much of like the wonderful success that Chris discussed in the UK, but then taking all that digital piece, taking the advances of telemedicine, and taking the multidisciplinary team with supportive nurses, social workers, etc., to really enhance the kind of care that each individual receives and each community receives through their primary care. Thank you.
Thank you very much, Mr. Gilbert. And now I'd like to give the floor to the Deputy Minister of Healthcare, Tatiana Semenova. And I'd like to say that the topic that she will tell us about is maybe one of the most important, because if we don't have well-prepared doctors of the primary care, so they have very important function. If we don't have this ongoing system of education, then it will be very hard to implement it all. So a couple of days ago, I was at the meeting held by Tatiana related to this ongoing education, and the tasks mentioned there were really huge and great. I think we all will be very interested in hearing this. Thank you, Grigory, dear colleagues. When with Alexei we agreed that I will come here to the Assembly of Moscow Health, it was very important, but we have discussed the range of the numbers of speeches, and yesterday when I saw the agenda I was surprised to see that, and today I realized the answer, and I changed a little bit my I would like to change a little bit my speech. I think now that I will change the priorities, the highlights in my speech. By the end of the round table, only really interested people stay, so usually not so many people, more oxygen, and the information stays better. I'm very happy to see that you're all still here and you're listening from the beginning to the end. So many speakers put the personnel at the very end. And at the plenary session I was very surprised that the Doctor 2.0, as Stefan Larsen said, it's the very, very last. So should someone criticize it? So it's a round table, right? It's not a plenary session. So why Doctor 2.0? Not doctor, but medical worker 2.0. A healthcare worker 2.0, social worker 2.0, and it all corresponds to what the President told the Federal Union yesterday. So yesterday Sergei Sobyanin said that, and Alexei. So what's Moscow? For me, Moscow, it's my motherland, and so Moscow and healthcare, it what made me who I am, for good or for bad. So when 9 years ago I was taken from a common clinical hospital, I can tell you that what was shown today, we saw today as like tasks for future, was already solved at the time. And if you have time and follow through all this exhibition, from what already the system can give to a person, it's a huge breakthrough. But citizens are not happy with the medical care for several reasons. But we have the key point. We have a person who connects and manages all these cases. In this case, it's Alexei Khrypun. So if you look at him, so who is here? First of all, he's a guarantor of the constituent right to the qualitative medical help. So because it's the president who guarantees that, and so because he's a minister, so he's responsible in front of the citizens. And on the other hand, he's a key employer of all medical workers of Moscow. So he is employer of chief doctors, and chief doctors then hire other doctors. So we have the unified goal to provide this medical health care by people working in comfortable condition. So we have one goal. It's not separate patient community and doctors community. Our patients, and I think most of people are here, are specialists, are doctors. So our patients are still not that happy with the medical care, because every day new and new standards and opportunities open new and new horizons. But not only that. There is no doubt, of course, it's communication. It's this opportunity that how doctor talks to a patient with this new patient. So tell me, Google, what kind of disease I have, but my doctor administered another drug. Of course, people understand that only they are responsible for their health. So in this way, we have a complete transformation, though we have some not very objective assessments of what we are doing. We should understand that, and that allow us to transform ourselves and our system. Who can teach this person that the person is responsible for their health, that they should have a healthy lifestyle? Only healthcare system can do that. So medical specialists should be these motivators. So how can we become this key motivator? First of all, there should be enough of us. So 35% of time for direct contact, 25% of talking to colleagues. I envy you. I'm really jealous. So thank you to our mayor that the professional community is here, because it raises your awareness and you may change your perspective to very common things. And it's very useful. And they spend 25% of their time for it. So I think it would be great to work in Kaiser system. So let's have a look on this on the other side, from the other side. So we should bring some new competences to our system. We need a new system of qualification improvement. So since last year we have this format of ongoing medical education. I haven't seen this in the key report today. If it's analytics, if it's key assembly, I was very surprised why they haven't shown what we are doing. But it's all right, because I know all the numbers and I can analyze them. So today at the portal, 74,000 specialists are registered who are working in Moscow. Moscow is a very specific city, not only because it's so huge, not only because it can include several capitals of other regions. So only officially it's 15 million people. And we have capitals that there are only tens of thousands, not even less than a million, in Russian constituents.
So let's take a look at different segments of our medical care. Federal medical care, private, closed and open. So there are very different things, individual entrepreneurs, whatever we can see on the market of health services. So 74,000 of specialists that are working in Moscow, that are verified in the medical register of medical workers. So only several thousands of them are active users that are involved in continuous education and training. And it's not about gaining some scores. You know, it's the ability to get flexible and soft skills in the modern context, because they work with virtual reality, with augmented reality, with surgeries, modules, tests, screening of competences, a diversity of different learning options. It's all available on our website, and each of you can use use this information depending on the competences that you use, maybe general competences or some narrow, highly specialized competences. So if we take a look at the proportion of people that work at the clinics, you can see that they will be important players on the market. So they should get to know what we talk about, and they should get access to this information that is shared here. So you can see some figures here. Most of them are subordinate to the minister, and the others report to other ministers and agencies. So there are many different providers, many different educational services that can be used. There are several projects that were implementing together with Moscow government, and Sergei Sobyanin was working today here, and he said that he's very happy that Moscow has become the pilot site for most of federal initiatives, and it means that some things started here in Moscow and now they are distributed throughout the country. So there are over 3,000 clinics that stick to the lean work principles. So it means that they have streamlined their logistics, they have created an accessible environment. But of course, Moscow is ahead of everybody else. But who is happy about the work of our Moscow clinics? Let's ask our citizens. And I guess not many will say that they're very happy with them. So the satisfaction, of course, medical people, medical specialist satisfaction and patient satisfaction are different things. But if we are going to use the technologies in the right way, I'm sure that we will be able to reach a very good balance. When people understand what to do and perceive well whatever they see in the clinics. Yekaterina added a new term in my vocabulary today: account manager. I guess we should talk more about it. I have just stopped explaining who HR is and what's the difference between the personnel, the head of personnel. I have to say it. Who is the main person? The chief doctor, the organizer of healthcare. But, for example, let's take a local doctor. Maybe he's also a key person because he organizes the work in his place. So maybe he needs nurses or other assistants. So they have to come up with suggestions and send them to the chief doctor so that all this knowledge and skills could be applied to life. And they should have certain competences, should have clinical thinking and able to analyze and synthesize different data, which is a very, very special skill. But before we start introducing account managers, we have some medical representatives, and maybe these representatives could help us. So each person should get their niche and do what they can as professional as possible. And now I would like just to thank you. It's good to see that Moscow is not only heading this way, but also the generator of new ideas, and we can't develop high-quality medical care without our competencies and professionalism and development, and this is the key to the effectiveness and efficiencies of healthcare sector overall. Tatiana is very convincing, and she talks about many different things passionately, and it's true, we have to discuss many different things. And now I would like to give the floor to Vladimir Gurdus, professor. Can you hear me? He is a professor, doctor of medical sciences. We have been speaking about telemedicine, digitalization, because it's an integral part of the changes that we are trying to implement. And so Professor Gurdus is one of people that is already applying different things. Thank you, Grigory. So as far as I understand, my address is going to be the last one during this session, so I'll try to be brief, and I hope that you will find it interesting. So unlike public healthcare, the primary healthcare sector has never been my stepchild, because I started working in the system since 1995, when we opened the first family clinics and worked together with insurance companies. So over 25 years I have been working with primary care, and before we move on to digitalization, I would like to elaborate on major trends in the world. First of all, the growth of costs, and the forecasts say that the costs will increase up to $10 trillion for medical services in the world by 2020 because of chronic patients and some critical diseases like cancer and other things. Now, speaking about the trends, first of all, the focus is changing from treatment towards health care, and this includes well-being, prevention, early intervention, prediction, personal approach, participative approach. You know, this paternalistic model is obsolete. I mean, when the patient explains something to the, when the doctors explain something to the patients have to take care of their health themselves, and this is very important to explain. And many things that could be resolved earlier through administrative tools won't work now anymore, because the attitudes are changing. Next thing is related to the service model and tariffification of services. It's related to different drugs, but this will be also applied to primary healthcare as well later on. So the future system of healthcare has to be accessible, and it means that people might want to go where they want to go. The system has to meet the individual needs of patients. So patient-focused model doesn't mean that the patient becomes a czar or the god, and so they can choose any kind of meals according to the menu. Basically, it means that it has to be very comfortable for the patient, so that the patient could get highly qualified medical help in line with modern technologies. So that was about the new requirements. Now, the fourth thing is creating superclusters, when the suppliers of medical services get together with aggregators and product suppliers and different employers to create a new model of services. So Google, Apple, Microsoft, Sberbank are all interested in working in healthcare. They demonstrate their interest, and this has to be taken into account. And finally, data consortia. It's about bringing different companies together so that we could get the global pool of medical data. And this medical data, of course, relates to the health indicators. Now, developing the digital medical care in the world, this requires a lot of investments, and in 2018 the number was $14.6 billion, with 70% on the American market, 20% on Chinese market, and 10% in European and other countries. So the major areas of investment: data analytics and early diagnostics, different medical applications, applications for telemedicine, insurtech, different medical devices, supporting for medical decision-making, sensors. Then digital medical care has been allocated as one of the major priorities for all Big Seven companies. And as to the investing in the U.S., it's highly differentiated. It has a highly differentiated character. Now, we have already discussed new approaches to healthcare, and it means that this system will become an ecosystem which will be patient-focused. So there will be interaction on different levels, of course in case of disease, but also in case of taking care of health. So Moscow healthcare sector is going to move towards this, and it's going to be about checkups, preventive recommendations, observation, getting different services. So this will become one single system, and without digital technologies, it could never be used. And I wanted to emphasize that medical care will never go to digital dimension completely. I don't think that there'll be a smart robot that will provide treatment to each patient in the next 20 years. Analytic and synthesizing work will have to be implemented by doctors. But anyway, digital systems will help to service not just 10 patients, but 12 million patients instead. Now, my next slide is about the primary healthcare, which will become the basis of ecosystem. This segment will provide the biggest number of contacts, and I can see 6 trends here. First of all, developing modern distance channels of interaction with patients, and this is telemedicine. We have launched a pilot project. I don't know if it's going to develop further. Maybe there'll be other initiatives, but I'm sure we are going to do a lot of things like that. Then the second thing is introducing big data technologies and systems for decision-making support. This should help the doctors, should save time and improve the quality of medical staff decisions. Then next thing is education and improving qualification of primary healthcare doctors, disaggregation of the primary care, attracting private operators to provide primary health care. The number of parameters could reach several hundreds in the past. I don't know what it's like today, but I can say that we should try to learn from our international colleagues and share their experience. And finally, my last slide. Why do we need digital technologies, telemedicine? They are instruments of ecosystem. Digital technologies can improve the access to primary care and improve its quality. It helps us to get more information about the patient. So this information will be accessible on different levels. You probably remember a discussion, about medical tests that sometimes they have to be taken twice. But if we have a single information system, once the tests have been taken, the information is available for everyone. Once the person is out of hospital, the information will be again accessible and available for all the specialists, those that monitor the health state or provide some support. So there are different technologies that can improve the interaction between patients and the doctors. You can get an online consultation of any specialist, and this technology has been already used widely. The exchange of medical data and introducing big data technologies and AI. And some examples of our digital services that are already working. We are already using all these things in our practice. So we have a service that is called Doctor Rядом, a doctor nearby. So we give over 60,000 online consultations as part of this service. And this year we expect to provide about 120,000 consultations. Most people are from Moscow, and we can actually discuss the topics and the subjects that are usually discussed during those consultations, but I don't really have much time. Then the service standard 24/7, and usually it takes 1.5 minutes to get a response from the doctor, and this is very convenient for the patient, of course. Next thing is monitoring and processing of analysis. So this is one of the options of dispensation for busy people who don't want to go anywhere, and they just need to take tests. And before giving their tests, they talk with the chatbot, so they get the recommendations based on the test that they have to take, and this is a range of tests that is available in different facilities all over Russia, and then it will be complete with telemedicine, and we have sold over 10,000 of programs like this.
And about 2,000 people already use this type of checkup. So about the time, how you have to spend for such a checkup overall, except going to the lab, about 30 minutes. That's all you have to do. You can agree that it's very convenient. It may be not very large clinical checkup, but it helps you highlight some areas that should be monitored. So prevention and healthy lifestyle. So there is already product together with dietitians when it's recommended to a patient some specific diets, taking into account the peculiarities, take into account their blood samples, just almost last slide. So it's a working technology, and we'll add some fitness recommendations, some lifestyle recommendations, and so on. So one before last. So that's what we tested together with the Department of Healthcare, monitoring of chronic patients and patients with low mobility. I think it's very convenient technology because a patient doesn't have to go to an outpatient clinic when it's not needed. If you have sufficient clinical technologies, the results are very interesting. And the last thing that we are working on is automated workplace of doctor that allows take the right medical decisions and will allow you to recognize speech and will allow to save time when talking to a patient. Thank you very much for your attention and thank you for inviting me here. Dear colleagues, I'm very glad to wrap up. So the global trend, the overall trend is clear. More and more outpatient clinics, primary care, so it takes more and more services. And Moscow is one of such trends. In Moscow, such a trend is also going. We're also observing such a trend, and I think it will continue. And one of the reasons for it is that the population is becoming older, and the number of services that we have to provide will only grow. And in the same proportion, it's not possible to proportionally increase the number of doctors. And I think that one of the reasons that's here, and I think this primary help, this physicians, common practice doctors, and these clinics, that's what we should really develop actively. And in some cases, I think we're maybe in some more favorable conditions than some other countries. For instance, in Germany or in the Netherlands, there was a focus on the primary care, on the physician. Then they realized that a physician, though he does a lot, he needs support of other specialists. And these group practices that now are very fostered in Germany, we have clinics for that. That's exactly this group practice that's already ready for use. And maybe that's the case when we can use, and in some time we'll be ahead of others. I can't say that the tasks that they're really huge and complex. It's like a whole bundle of tasks. It's for education, digitalization, change of doctors, taking into account that our patient changed, and with huge speed, everything's changing. So patients receive diagnosis before coming to doctors, and the level of knowledge for their specific disease may be even larger than a physician has, and we can't just not take into account. And there are many issues, and of course in Moscow at least they should be solved, maybe everywhere. I'd just like to say a couple of words as I work with physicians. So the professional standard of a physician, it's a topic that's been discussed for many years, but in 2020 we are promised to have some description of what it is, what a physician is. There are no criteria through which we can say that this doctor deals with his or her responsibilities and this doctor does not. So now there is an order of creating the system of family doctors from 1992. So a lot of years, 28 years passed, and now this order is still, this law is still in order, and there are problems that we have to address. We have to change the attitude of doctors toward patients. We are quite likely unhappy. So as a doctor, I often feel the same, like I'm doing my best, I'm really trying. I look at the clinics, but still the level of satisfaction of patients is very low. Only 9% of patients think that the medical help is good or very good. I don't say that it's objective or fair, but we should hear that. We can't change patients completely. We have to deal with these patients, change ourselves. And patients should, maybe if not love us, still understand us. And so I'm wrapping it up because our time is over. So the topic is really huge, limitless, and I'd like to say thank you to our speakers for their interesting reports and to support me and So let's give them a round of applause.